So we're going to be demonstrating or simulating a epidural catheter insertion. So firstly, we want to check our chart, make sure that they are not on any anticoagulation, check their INRs and their platelets, as well as administer a preload crystalloid infusion for the procedure. And then we're going to ensure that our allergies are checked and our consents are signed for the procedure itself. Once this is done, we're going to apply all of our ASA standard monitors and make sure that our alarms are audible. And then we're going to have the patient sit up on the side of the bed, and we're going to palpate the superior iliac crest and then find our L3, L4, or L4, L5 interspace. And once we find this interspace, we're going to indent it and mark it with our fingernail, and then we will proceed further with our procedure. We're going to wash our hands and don our hair covering as well as our face protection, our eye protection, and then a face mask. And then we would wash our hands, and then we'll open up our sterile kit. So our sterile kit will come in a plastic covering. We'll remove that covering and then open up sterilely. So away from us, towards us, left and right, maintaining our sterile borders. There would be a kit of sterile gloves in this kit, so I will cut and then don those sterilely. So once my sterile gloves have been donned, we're going to look inside of our kit and see what is inside. So like I said, also I would have my face covering, my hair covering, as well as my eye protection on with my sterile gloves. We can see our iodine prep tray. We can take this sterile packet of iodine, we would open it and then pour it into the prep tray, and then we can throw this in the trash. We would begin by taking our first sponge, dipping it in the iodine, and then working at our insertion site in circular motions. And then once we go in 3 or 4 counterclockwise circular motions, we will go ahead and throw that in the trash sterilely. We would repeat this process 2 more times, ensuring that we are widening our workspace and then making sure that we are maintaining sterility. And the final third. And then we would allow this to dry for 3 minutes and let it set. Once 3 minutes has elapsed and our target area is now dry, we can take our sterile drape, our fenestrated drape, and then ensuring that we are grabbing the edges, and then we will step away from the sterile field and allow the drape to fall and open up. We could remove, we don't want to shake this over the sterile field because it can cause dust particles to go over our sterile field, and then we would remove our adhesive backing and then place the fenestrated area over our targeted interspace and allow the adhesive backing to stick to the patient. Once our patient is draped, we can remove these sterile drapes and extra towels were sitting on top. We can just remove these and throw them in either the trash can or another sterile area. We want to double check all of our vials. So we have 10 mils of sodium chloride. We want to check the expiration date on those as well. We have our 1% lidocaine. This is for our skin wheel. And then we have our lidocaine with epi, and this is our test dose. So we want to make sure that the lidocaine is 1.5%, as well as our epinephrine is 1 to 200,000 in ratio. And this is going to be a total of 5 mils. Once these are done, we can take our 3 mil syringe with our filter needle, and then we would take our ampule and crack it sterilely, then use our filter needle to draw up our lidocaine for our skin wheel. Then once that is done, we can remove our filter needle and then apply it to our 20 mil syringe and then draw up our test dose for our epidural. Once this is all done, we are ready to proceed and we can continue. So once our patient is draped and dry, we can go further into our kit. So we have our epidural catheter here. We have our loss of resistance syringe, as well as a 3 mil and a 20 mil with our epidural needle, a filter needle, as well as our filter for our actual catheter. And then we have our 10 mils of sodium chloride. We have our 5 mil ampule of 1% lidocaine for our skin wheel. And then we have our test dose. We want to make sure that our test dose is 1.5% lidocaine with 1 to 200,000 epinephrine, and it gives us a total of 5 milliliters. So we would take these, and then normally we would have a 5 mil syringe, which we could draw up our lidocaine. We would take our ampule and then break it sterilely, and then insert our filter needle with our syringe and draw up our lidocaine. And then we would do the same thing for our test dose. So we will take our 3 mil syringe and attach our filter needle, and then we would break our ampule and then draw up our test dose, while again confirming that we are drawing up the proper percentage as well as concentration of epinephrine and lidocaine for our test dose. Once that is ready, we are ready to proceed with the procedure. All right, once we are ready to proceed with our procedure, we're going to again double check our interspinal space and make sure we still have our correct anatomy. We can then take our lidocaine syringe and injecting at a 15-degree, first we get our sub-Q skin wheel and then a 15-degree caudal direction towards the umbilicus, injecting as we go in, or we can inject as we come out. And this is to numb up the area. Once this is done, we're going to take our epidural needle with our stylet inside. We are going to ensure that our bevel is up. We can then go, again, double checking our interspinous space. We're going to insert the needle into the patient, and then we're going to advance through the subcutaneous tissue and into the interspinous ligament, and where it will then be anchored in the spinal column. Once it is anchored and we have that gritty feeling, we're going to stop there and not advance any further. We can remove our stylet, and then we will attach our loss of resistance syringe. Once our loss of resistance syringe is attached on an actual patient that is not foam, this plunger would not be able to go further. So we're going to anchor our needle with our non-dominant fingers, and with our hand we will advance further while maintaining pressure and checking loss of resistance as we advance. So we're going to traverse the ligamentous flavum and then wait for loss of resistance while, like I said, advancing further. We can also anchor here with our non-dominant hand and advance millimeter by millimeter, and then double check afterwards, either one that works. But we want to make sure we are anchoring the needle and not allowing it to move forward or backward between puffs. So as we advance, and we will say that we maintain resistance, and then we traverse through the ligamentum flavum, we feel the pop. We will have loss of resistance. We're going to stop there and not advance any further. So we want to anchor our needle without advancing it either left down or back. So we're going to remove our loss of resistance syringe. We're going to place that here, and then we're going to insert our catheter with our guide attached to it, and we will insert our catheter. We want to make note of the depth of the epidural needle. Currently we're at 5 centimeters, and we want to insert our epidural catheter 4 to 5 centimeters past the tip of the needle. So if we are 5 centimeters in, we want to insert to a depth of 9 to 11 centimeters with epidural catheter to ensure that we are that 4 to 5 centimeter depth past the tip of the needle. Once that is in, we can remove our epidural needle while ensuring that the catheter stays in place. And then we will secure our catheter with our hand as we pull the needle off. There would be less catheter exposed on an actual patient because I'll actually be able to insert it deeper. And we will place that in our sharps container, and then we will attach our port to our epidural catheter. So maintaining anchoring of the epidural catheter, we will place our port and secure it, and then we will attach our syringe and aspirate and ensure that we don't have any heme or CSF. And if that is negative, we will then attach our test dose syringe. So with our test dose syringe attached, we will inject 3 mils. We will inject 3 mils of our lidocaine and epi mix into the patient, and we will wait 3 to 5 minutes to ensure that we don't have an intrathecal injection, and look for signs and symptoms such as the increased heart rate, metallic taste, ringing in the ears, tinnitus, and any signs and symptoms of LAST. Once this is confirmed and our test dose is negative, we're going to aspirate again, and then we're going to administer our bolus of 0.5% or 1/4% bupivacaine and attach this to our PCA pump. Once we administer our bolus dose, we will secure the catheter. So we have this foam block. We can place the catheter inside and then use the adhesive and stick it to the patient. And then we can place a sterile tegaderm over this while draping the catheter upwards. And then we would attach our filter to the end of our port and then attach this to the PCA pump as well. After this is done, they are attached to the epidural pump. We want to reassess their vital signs and ensure that we don't have any complications.